Hi, good evening, everybody. My name is Dr. Nicole Phillips. I am a plastic surgeon at Spectrum Health Lakeland and want to welcome you tonight to our seminar. As you know, October is Breast Cancer Awareness Month, and so we thought it was the right time to give this talk on breast cancer surgery and reconstruction. I'm joined tonight by Dr. Rapciak, who is one of my colleagues in general surgery, and tonight we'll be going through the basics of what to expect if you're given a breast cancer diagnosis. Next slide, thank you. So I want to just let you know, just sort of highlight that there is a Q&A section. You can enter your questions there throughout the talk. We will try and get to as many of these as we can when we've finished our presentations, and just go ahead and enter them there while we're speaking. And just a brief disclaimer, we're both members of the Spectrum Health Lakeland staff. We do have some patient photographs and some graphic images included, but all of these images are used with patient permission. All right, so without any further ado, I'll pass it off to Dr. Rapciak.
Good evening, everyone. Thank you for joining us tonight. My name is Dr. Rapciak. I'm a breast and general surgeon with the Southwestern Medical Clinic. Tonight, I'll be talking to you briefly about breast cancer surgery. Next slide. What is breast cancer? So breast cancer is the growth of abnormal cells that divide and damage normal tissue. The first picture here on the left depicts the typical breast. Here you have lobules, which is where the milk ducts and glands are. And then the duct is the actual channel through which the milk would then travel down to the nipple. The breast is also surrounded by fatty tissue, which is depicted by the yellow in that picture. Ductal cancer in situ, or stage 0, very early breast cancer, is where the normal duct is replaced by cells that are abnormal. From the studies that have been done in this field, these abnormal cancer cells typically occur because of damage to the replication or the growth of the cells, and the green depicts these abnormal cells. As you can see, they grow at different rates. The cancer cells can also be in different shapes and sizes. When it comes to the most common type of breast cancer, ductal cancer is the most common type of breast cancer. And breast cancer, typically 70% of it will be diagnosed in women over 50. Next slide. Breast cancer statistics. So breast cancer diagnoses, it is the most common cancer that's among women in the United States. It is also the second leading cause of cancer-related deaths in women. If you get past the age of 70 and when you have more than 8 friends that are female, you can expect one of your friends to be diagnosed with breast cancer. So the average breast cancer risk is about 12.5, almost 13%. In Berrien County, with statistics from 2019, there's about 115 new cases that are detected. If we look at the entire state of Michigan for a population of 100,000, about 120 of those are the new types of cases. The graph on the right really depicts the statistics of breast cancer diagnoses. As we get past age 35, obviously that number keeps climbing. And really after 50 is when, again, 70% of breast cancers are diagnosed. Next slide. So identifying risk factors for breast cancer. There are certainly risk factors that are modified and things that we can change. There are also others that we cannot change. Age being the biggest risk factor that we cannot modify. As we get older, our breast cancer risk increases. A lot of this, again, has to do with the DNA damage that can occur in cells as they're replicating, which then leads to abnormal cells, which then leads to tumors, and then that diagnosis of breast cancer. Gender is another risk factor we cannot modify. About 99% of breast cancer diagnoses actually occur in women, and about 1% occur in men. Menstrual factors, having an early start of your menses before the age of 12 or starting menopause after the age of 55 are both risk factors that we just can't control. Having no children, having a family history of breast cancer, genetic factors, race, ethnicity, all of these also play a big part into the risk factors for breast cancer. This graph on the right really depicts what we know and don't know to this point, that about 70 to 80% of breast cancer is sporadic, meaning we don't know the reason why women have it and why it has formed. A smaller amount of that is familial breast cancer. So this is very important for first-degree relatives. So if you have a sister, if you have a daughter, if you have a mother who has been diagnosed with breast cancer, it's very important to bring that up with your doctor. And then there's the genetic mutations, the BRCA1, BRCA2 mutations that also account from 5 to 10% of the breast cancer diagnoses. Next slide. So risk factors that all of us can work on to help decrease our risk of breast cancer. Modifiable risk factors include reproductive factors. So having children before the age of 30 is actually protective against breast cancer. A lot of that has to do with the fact that as you're pregnant and then as you are hopefully breastfeeding or have lactation that occurs, during that process, the menstrual cycle will typically halt. The effect of estrogen on the breast cells is also halted, and all of that is actually protective for the breast against breast cancer because they would not be reproducing during that time. Other factors that can be modified is history of hormone replacement therapy, maintaining a healthy weight. This is one that I really want to stress in my presentation, is maintaining a healthy weight. It's extremely important for women who are postmenopausal. They've done multiple studies and identified factors such as BMI over 25, which is your body mass index. If you are overweight or obese and you are postmenopausal, that certainly is a risk factor for breast cancer. And again, it's a risk factor that we can all work on modifying. Alcohol consumption is another risk factor. Studies have shown that women who have more than 1 drink a day, some women who have more than 2 to 3 drinks a week have even been found to have an elevated risk for breast cancer. And some studies have actually identified a 15% increased risk. So we may not think about it, you know, especially if you're younger and you might have multiple drinks, you go out with your friends on the weekends, all of those add up and they increase your risk of breast cancer. Physical activity really goes hand in hand with a healthy weight. Maintaining at least a routine exercise regimen is really important to help decrease your risk of breast cancer. There have also been studies that have found that shift work, working the night shift, also increases risks of different types of cancers, and breast cancer is one of them. Next slide. So how is breast cancer detected? Screening mammography starting at the age of 40 is the #1 tool we have these days to detect breast cancer. If you look back at data from before the 1980s, the death rate from breast cancer was really high. Between the 90s to the 2000s, because of screening mammography and the push to have screening mammograms for women, the death rate has actually decreased by about 40%, which is huge for all of our female colleagues and for just the entire population. Identifiable risk factors for breast cancer, also on a history and physical exam. It's important to bring up anything to your doctor's attention. Feeling for your breasts, and this is a nice image of lemons that depicts the different shapes and sizes our breasts can be, but feeling for an abnormal thickness, feeling for dimpling, nipple crustation, redness, any changes that look like an orange peel or feel like an orange peel, any sort of bumps or sores. These are really important things to bring up to your doctor. I understand that we don't recommend self-breast exams these days based on society guidelines, but I still think it's very important for women to be familiar with their breasts, to be familiar with what they feel and what they're like, especially as your menstrual cycles may change or as you notice or don't notice that the size of your breast changes. Just a little tidbit about mammography. Mammography is great. It can detect very small tumors or growths within the breast, anything from 0.5 centimeter or smaller to even up to 1.5 centimeters. Really, the tumors that we may feel on our exams are 1.5 centimeters to closer to 2 centimeters. So this is why screening mammography is so important. Because it helps to identify these tumors either when they're smaller. Sometimes it can help to just identify some calcium deposits that then need to be worked up further. At our facility, we do have access to also MRI studies. We have access to 3D mammography. So there's a lot of different tools, and a lot of this is guided by your family doctor and can also be guided by the radiologist. Next slide. So stages of breast cancer. Stages of breast cancer really have been from 0 to 4. It was nice before 2018 when we had sort of a simplified version of what breast cancer staging was like. We typically would base it off of the actual size of the tumor, and we would base it off of the lymph node involvement. Since 2018 and since we've had a lot of biogenetic testing available, breast cancer staging has really become quite complex. When we stage a breast cancer diagnosis, oftentimes nowadays we'll also include the grade of what the tumor is like. We'll include what the receptor status is, whether it's ER/PR positive, the HER2 stage. All of that is part of now the new staging for breast cancer. And another very important tool in terms of staging is identifying what the tumor was on its initial diagnosis, meaning anatomically, and then prognostically, meaning what the tumor and the final stage is after we take it out. These stages can change, and that's something that we certainly talk to our patients about, that before surgery, you can have one stage of breast cancer, and then after you have about a 10% chance that could be upstaged. So that's certainly something to consider. The other very important point about staging is really as the stages increase, the survival, especially the 5-year survival, really decreases. So someone, let's say, who's diagnosed with a stage 0 breast cancer, like a ductal carcinoma in situ, or a very tiny invasive cancer, these stages, survival of 5 years is anywhere from 98 to 100%. Now, if we move on to stage 4, where you have a bigger tumor, maybe you've let that tumor grow through your skin, or it's just gotten, out of control and it's in your lymph nodes or in other organs. If it's a stage 4, that 5-year survival will really decrease, and it could be closer to like 16%. So it's very important for a staging of breast cancer, for screening mammography, to really pick up cancer before there are any symptoms of cancer. And if we find it and detect it earlier, the chances of survival and the treatment is much more successful than if a cancer is picked up later in life. Next slide. So what kind of surgical options do we have for cancer? There's really 2. These days, breast conservation surgery and mastectomy are the 2 options that we have available. If you were to look back in the 1800s at Halsted and the first real surgical approach to breast cancer treatment, things were done a whole lot differently. Historically speaking, breast cancer was treated with the removal of the breast, removal of the muscle, and all of the lymph nodes. Even in the 60s and 70s, all of the lymph nodes were removed and women were left with a lot of swelling in their arm. They were left with disfigurement. We did not have reconstruction at that point. And so not only was a woman dealing with breast cancer, but she really was disfigured afterwards, and she had to live with that every day. So I think breast cancer surgery has certainly come a long way. For breast reconstruction and breast conservation surgery, in this scenario, tumors are typically smaller, and what we can offer is the removal of parts of the breast called a partial mastectomy, plus or minus the sampling of lymph nodes. So it's called a sentinel lymph node biopsy. What this does is it will help a woman preserve the shape, the contour of her breast. This is aesthetically something that is appealing because women do want to preserve their breasts. And so this is one option. The downsides to breast conservation surgery and followed by therapy is that most women do need to have radiation therapy to follow. And most women after breast conservation surgery are always at an elevated risk for having a recurrence. So a recurrence of breast cancer can be anywhere from 5 to 8% in that breast. And so those are sort of the two things that we need to always consider when we are trying to save a breast, that needs to be taken as part of the treatment for breast cancer if this option is selected. Next slide. So this is just a depiction of a mastectomy. This is the removal of the entire breast. So in a mastectomy, the breast comes out plus or minus the lymph nodes again. With most of the breast tissue being gone, the chance of a recurrence on the same side here with breast cancer is extremely low, if almost non-existent. There are certainly always a few breast cells that may be left behind, but again, the purpose of a mastectomy is to remove all of the breast tissue. This is a treatment for breast cancer. It can also be branched out to treatments for prophylaxis, especially in women who might be BRCA mutation positive or BRCA1 or BRCA2. In those cases, women can also qualify for what's called a nipple or skin-sparing mastectomy. We would do these in conjunction with Dr. Phillips, typically for reconstruction to follow. But a mastectomy is simply just the removal of the whole breast. And if this treatment option, surgical treatment option, is selected by our patients, then the need for radiation typically does not exist. So really the two options are doing a mastectomy or having breast conservation surgery, which then turns into really breast conservation treatment, which is with that radiation therapy. Simple versus a modified radical mastectomy. The big difference between these is how many lymph nodes are taken. The picture depicts two little circles that are in green there. And so there's different levels of lymph nodes that are within the armpit and that travel up into the clavicle region. And it really just varies on how many lymph nodes need to be taken out. And that's something we're going to talk about in the upcoming slide. Next slide. So how do we localize or find where the tumor is? For surgery, one fantastic thing we can offer here for localization at Lakeland is actually the Savvy Scout localizer. This is a deflector that's a radar localization deflector. It is smaller than a dime, and it localizes a tumor without a wire. This is a fantastic tool that we've had probably for the last 5 to 10 years, where women don't have to go through a wire localization where someone in a radiology department has to stick a wire down into the tumor. Then they have to travel through the hospital, have their surgery while there's a wire that they can physically feel and see that's sticking through their breast. So this is really revolutionary in terms of patient comfort and just the quality of care that they can receive. This localization device is something that can be placed anytime before the surgery. It can stay in as long as necessary. So some women may need to undergo chemotherapy, and this is a great device that can be placed ahead of time. They can have their chemotherapy, and then afterwards they can complete their surgery. During the surgery, this device can detect up to a range of 6 centimeters. It's very accurate, and it's also compatible with all of the different imaging studies. So we may order a mammogram before someone has chemotherapy. We'll repeat it at the end of their treatment, and these devices are great because we can use them while that patient is getting their entire treatment for their breast cancer. Next slide. So how about the lymph nodes? I briefly touched upon the lymph nodes earlier. The reason the lymph nodes are so very important is because the lymph nodes really determine the long-term prognosis and survival of a patient once they are found to have breast cancer. So the lymph nodes that are in the armpit or the axillary lymph nodes, these are the prognostic factors, meaning again, they will determine the prognosis and the long-term sort of survival of that patient. So oftentimes we will proceed with what's called a sentinel lymph node biopsy, and this would be done at the same time as the lumpectomy or the partial mastectomy. Next slide. So for the sentinel lymph node biopsy, our patients would go into the nuclear medicine department. There's a radioactive substance or dye that's injected near where the tumor, the breast cancer is. That dye or that substance will then travel into the lymph nodes in the armpit. And these are the lymph nodes that then we can radioactively follow with what's called a gamma probe. And we're able to see exactly which ones need to come out. These are the sort of the first lymph nodes that come from that tumor bed. And so it's really important that we're able to identify just the first few lymph nodes. Sentinel lymph node biopsy has been really revolutionary. It has been something that, again, in the 60s, or if we even went back 2 decades ago, a lot of axillary lymph node dissections were happening where all of the lymph nodes in the armpit would have to come out. And now a lot of recommendations and data is really going away from that because there's a lot of comorbidity and complications from having all your lymph nodes taken out. So we have found that less is oftentimes more in the case of lymph node biopsy. Next slide. So how do we decide, how do, other women, patients who may be in these situations decide on what kind of surgical cancer treatment option to go with? A lot of this is just shared decision-making. It's really a discussion I would have with my patient in the office. My point of view is really looking at the tumor, looking at the size, looking at how far or close to the nipple it is, what kind of family history the patient may have. It's looking at whether the tumor is just in one spot, whether it's multifocal, whether it's multicentric, it's throughout the entire breast. And so these are sort of viewpoints that I look at to help patients reach a decision. From a patient's viewpoint, obviously it's important to consider what is the chance of a recurrence I may have with breast cancer if I decide. Psychologically, how am I going to deal with waking up, looking in the mirror every day with the results that I have? And these are the results I'll have to live with for the rest of my life. So these are just really important shared decision making models that we do every day with our breast cancer patients, with other cancer patients. And it's just important, I think, for everyone to understand where the collaboration happens. Breast cancer treatment is certainly not an easy approach. It's something where we have to consider more than just the body. We have to consider a woman's spiritual as well as mental health. And so I think it's very important to outline the shared decision making. Some of the new and future treatment approaches for breast cancer will be focusing a lot on biogenetics. There's a big push for precision medicine where each tumor that a patient has will be really individualized in terms of its behavior and then the treatment to tailor that. So those are sort of the new and exciting future updates for breast cancer treatment. Next slide. So here at Spectrum Health Lakeland, we have a wonderful breast cancer program. That picture on the right depicts Dr. Agilda. He is our breast cancer program director. He is a wonderful radiation oncologist. He is there with our device that we have here for intraoperative radiation therapy. I don't want to take away from the purpose of our presentation today, but we do offer IORT at our facility. This is a great treatment option for women who can't complete whole breast radiation. And if they're candidates, they can then qualify for intraoperative radiation therapy. Our breast cancer program is accredited by the NAPBC, which holds the highest standard of care for patients with breast cancer. We are very proud to be able to offer breast cancer care that's comprehensive, close to home. We're very excited to have Dr. Phillips and to work closely and really be able to help women where they feel safe and comfortable in their community. Our breast cancer program also has a multidisciplinary team. We meet every week. We go over the new diagnoses of breast cancers. We review anyone who's had surgery for breast cancer. And it's a wonderful team approach where cancer doctors, radiation doctors, all of the other specialties, nurse navigators, all of us meet together, review the imaging, we look at the pathology, and are able to really have a comprehensive plan for our patients. Part of the breast cancer program is our high-risk cancer center. Here we will refer patients who could be high risk for breast cancer, anyone who needs a clinical breast exam and a risk assessment. Catherine Vera, who's our nurse practitioner, is a great tool that is part of this high-risk cancer program. She does a fantastic job leading our patients through the risk assessment and determining what other care they need. Part of our breast cancer program is also lymphedema therapy, and as I mentioned, the wireless localization we can offer. Without further ado, I would like to turn this presentation to Dr. Phillips.
All right, well, thank you so much. Thanks so much, Dr. Rapciak, for that wonderful presentation. Next slide. So I'm going to talk about breast reconstruction today, and I want to start by highlighting that this is a really personal decision for every patient. Dr. Rapciak brought up the concept of shared decision-making. I think that's a really wonderful way to frame this and to think about this. You know, when we're approaching a new breast cancer diagnosis, we need to treat the cancer. Obviously, that's the goal of our treatment from everyone's perspective on that multidisciplinary team. But we also really want to think about, you know, what's the impact of treatment on you as a person, on your social, personal, sexual well-being? How's it going to affect your health, your function? What's going to be the, you know, impact on your job? And what does breast reconstruction have to offer for you in terms of impacting those factors? So can breast reconstruction help you feel more like yourself again after surgery? Or is it something that at this point in time is just too complicated, is too much to think about, and you want to focus on the cancer care and get to the other side of it, and that's the choice that's right for you. And so I wanted to start by saying, you know, it's really a very personal decision. Not every patient chooses to move forward with breast reconstruction. Some people choose to move forward with it at a later date, and we'll talk about some of those decision-making points. But there's no wrong decision. Every choice is the right choice for that patient, and our job is to help guide you through those choices. Next slide, please. So what to expect in terms of what does breast reconstruction involve? One of the things I really like to highlight right away is the fact that this is usually a series of surgeries. You know, sometimes if the stars align perfectly and really just every factor comes together, we can get away with one surgery to do breast reconstruction, but much more often it's 2 or 3 or even 4 surgeries to get through to the final end result. Because there's a couple of months in between each surgery, that means that the whole process can take up to a year or maybe even longer. So I usually get to know my breast cancer patients quite well. And the breasts, unfortunately, will never be what you had before. They're never going to be the same as before you had a cancer diagnosis. My goal is really, again, for women who've decided to move forward with breast reconstruction, is really to get you to a place where you feel comfortable in clothing, you feel comfortable socially and with your partner, but we're never going to be able to restore exactly what was there before. It's never too late to have breast reconstruction. I think that's another point to highlight here. Again, there are some patients who really want to focus on getting through the cancer diagnosis, getting on the other side of the cancer treatment, and then later on come to think, well, I actually really think I would like to do breast reconstruction. There's no time limit on it. Breast cancer is a diagnosis that's going to impact you for the rest of your life, and your medical insurance company recognizes that and will help cover procedures at any point in time. So it could be a year out, 5 years out, 10 years out. All of these procedures are covered. And procedures on the opposite side, to the cancer side, are also covered. So that can be a lift or a reduction on the opposite side if you choose not to have a two-sided procedure. And again, that can happen at any point in time. Next slide, please. So when you first come to see me, there's a lot of information you're sorting through, and really what we need to decide up front there's sort of two major decision points we need to decide between. The first is, are we going to do what's called an immediate reconstruction or a delayed reconstruction? So in an immediate reconstruction, we reconstruct the breast at the same time as the mastectomy. And I should highlight that when I'm talking about breast reconstruction, for the most part, I'm talking about women who've elected to move forward with a mastectomy, as Dr. Rapciak was talking about. There are some options for women who have had breast conservation surgery, and I'll talk about those at the end. But mostly here, what I'm going to be talking about are reconstruction after a mastectomy. So we're going to do this at the same time. So the mastectomy is going to be performed, and on the same day, we're going to start moving forward with the breast reconstruction. Or are we going to do the breast reconstruction at a later date? Again, those can be that decision can be based on personal goals for healing and recovery. Going back to shared decision making, sometimes there's going to be times that I am going to, from a medical perspective, recommend to you that we wait. If there are medical factors that make your risk of complications after reconstruction quite high, so if you're a smoker, if you have diabetes, obesity, these are all factors that come into play. If you're going to need radiation is a major one that we take into consideration. Not any single one of these usually is sort of a one and done, but any of these factors taken, all together. And again, I'll help sort through this with you. And again, it doesn't mean that you can't have reconstruction in the future. It just means it might not be a good idea right up front. The second major decision is, do you want to use implants, or do you want to do what we call tissue-based reconstruction, or some other terms you might hear are autologous reconstruction, or flaps. And I'll talk about what flaps are. I'll give a little bit of information on that coming up soon. But basically, it's, do you want to use your own tissue, or do you want to use implants? This is, again, a really personal decision. It can be based on your desire to be bigger or smaller than you are after reconstruction. If you're going to be having surgery on one or both breasts comes into play here. Do you have enough tissue? If you want to do tissue-based reconstruction, do you have enough for reconstruction? Some women are too thin and don't have the option to use their own tissue. And I know that sounds like a crazy phrase to say too thin, but really we need to have enough tissue to rebuild a breast, and some women don't have that option. And then finally, are you going to have radiation afterwards? And radiation really changes the skin and the soft tissue in a long-term way. And that can make our decision-making tree a little bit more complicated when it comes to reconstruction. Again, I don't want to go too far down any one pathway tonight. I really want to provide a broad overview. But sometimes, because of radiation, we have to choose a different type of reconstruction than maybe what would be our preference otherwise. Next slide, please. So our first option that we'll start talking through is implant-based reconstruction. I think most people, have heard of breast implants. This is something that's familiar to most people, and this is, relatively speaking, the more simple option. Next slide, please. This is often a two-staged procedure. So this slide is actually showing us what we call a tissue expander. So a tissue expander, which is actually fully inflated in these photos, but is really like a collapsible implant. So it's a silicone shell that can be totally flat, and then we fill it up with fluid over time. The reason why we often place a tissue expander at the time of the mastectomy and rather than a full implant is that this allows a little bit more time for the tissue after the breast cancer surgery to recover. So when the breast tissue is being removed, along with the breast cancer, we're also removing arteries and veins and things that supply the skin overlying the breast and keep that skin healthy. And so sometimes that tissue needs a little bit of time to recover afterwards. And so we place this flatter implant in there, which is more gentle on the tissue, and we slowly expand it over time. The other reason to use an expander is, again, if you want to be bigger or smaller than what you start out with, this helps me to reshape the skin and the tissue pocket that we're going to put the implant in eventually. And so you are going to be an active participant in this case in terms of deciding, okay, I like, we're filled to this point. I like it here. This is where we're going to stop. This is the implant size we're going to use. Next slide, please. So I want to show an example of implant-based reconstruction and show you what happens at that second stage. So as I mentioned, the tissue expander usually is placed at the time of surgery, and then a couple of months later we go in and place the permanent implant. And I wanted to show some examples of what this looks like at various points in time. I also want to highlight the fact that we have a really wonderful breast cancer survivor community. Lots of women who are willing to speak with other patients. They've been through it. They're on the other side. They can talk you through their experience. And it's for that reason as well that the patients shown here have agreed to show their photographs, because they want patients to be educated moving forward. All right, next slide, please. So this is a young lady who came to talk about breast reconstruction and was going to be moving forward with a bilateral mastectomy. Next slide, please. And here's what she looked like immediately after the mastectomies were performed. So in this picture, the tissue expanders are in place. They're underneath the muscle. But you can see that there's no fill that's been added here. And that's because you might see on that, on the breast that looks like on the left of your screen there's some bruising. And that's just a sign that that skin is a little unhappy. It wants a little bit of time to recover. And so that's just going to give it some time to recover before we start filling them up. Next slide, please. And here she is a couple of months later with those expanders fully filled out and at a size that she was happy with. And we're getting ready to proceed with an implant-based reconstruction, switching out to the implants. And there are areas marked for little revisions, little touch-ups. Again, I'll sort of highlight those later, but we often will do things where we take fat from one part of the body and then transfer it over to help fill in some of the gaps and help round out some of the curves, just like we have in our native breasts. Next slide, please. So here's the patient before and the after image shown here is about 11 months after the initial surgery. So you can see, again, this was a multi-stage journey where she looked quite different along the way, but at the end, she has a reconstruction that is pretty close to what she started out with, that fills out her clothing well, and that's helped her feel more comfortable moving forward. Next slide, please. And this is just showing some different views. Next slide, please. Next slide, please. Here's another example. This is a patient who opted to proceed with just one-sided mastectomy, so what we call a unilateral mastectomy. So only the breast that had the cancer diagnosis was going to be removed. Next slide, please. And this is just showing her preoperative photographs. Next slide, please. And here she is with that tissue expander in place, fully expanded. Now you can see this is a nice match to her native breast on the left side. But this patient actually desired a more lifted look and wanted to combine her reconstruction with a lift on the other side. Next slide, please. And this is, again, just showing some photos of that expander in place. Next slide, please. And here she is after the lift and after the implant. Now this is a couple of months out from her surgery. They're still healing and settling to go on, but it's a nice match for her and again meets her goals for reconstruction. Next slide, please. And just showing from different angles. Next slide, please. And you'll see in all of these photographs, as I mentioned at the beginning, it's never a perfect match to what was there before. Again, our goals are to really just restore confidence and comfort, especially in clothing and in social situations. So this is another young lady who decided to proceed with a unilateral or one-sided mastectomy and reconstruction. Next slide, please. And next slide, please. And this is her with her implant in place on that side. Next slide, please. And again, you can see this isn't a perfect match, especially outside of clothing. And this patient is actually still undergoing, she has another surgery planned, so there's further revisions to come. Next slide, please. But you can see inside of a bra and inside of clothing is a very good match and very difficult to tell from the outside. Next slide, please. So I'm going to talk briefly about tissue-based reconstruction, or flaps. Next slide, please. So what is a flap? What's that term mean? So it would be lovely if we could just pluck out tissue from our belly, which is most of the time where this tissue comes from, and just sort of stuff it into our bra, or stuff it into our chest. I think I'd be out of a job if that became a reality, but we really need to, when we move tissue from one part of the body to another, we have to carry a blood supply with it. It has to stay alive by staying attached to a form of blood supply. Most commonly, we take these flaps from the abdomen. Other options do exist. Just for the interest of time tonight, I'm not going to touch on those other options, but there are other areas that we can take tissue from if you don't have enough abdominal tissue. Next slide, please. So I do this drawing for everyone who comes to my clinic, just to explain the concepts of a flap. There are two different types of flaps. One is what we call a pedicled flap, or a flap that has kind of a leash to it. It stays attached to its blood supply. And the second option is what we call a free flap, where the blood supply is reattached at a site far away. So we basically take the tissue off with an artery and vein that we have dissected out and we have freed up from where it comes from originally, and then we reconnect it to an artery and a vein inside of the chest. Next slide, please. Oh, can you go back, please? Yeah, so this is this one, thanks. This is what we call a pedicled flap, and the TRAM flap stands for transverse rectus abdominis myocutaneous flap. Basically what this means is we're taking the flap, we're taking that abdominal tissue attached to its leash from above. And when we do that, we actually have to move the whole muscle, your rectus abdominis muscle, your six-pack muscle, because that's where the blood supply is coming through. Because it's coming through that muscle, it moves with it, it rotates into the breast with the flap. And so you're actually left with a defect in your abdominal wall, and that purple drawing there is showing that we reconstruct that with a piece of mesh. Now that works very nicely for most people, but it does put you at a slight risk of an abdominal hernia or a bulge. Next slide, please. And so one of the options that we, as plastic surgeons, came up with to get rid of that risk of hernia or bulge is to do a free flap, where we remove the tissue and we reconnect it somewhere else. This is most commonly the DIEP flap, and again, you can see here there's a little piece of tissue with the artery and vein kind of dangling off of it, and the muscles have stayed attached, so they're still in the abdomen where they were before, and we reconnect that piece of tissue up to a blood vessel in the chest, and that's usually done under a microscope, and that's called free flap surgery or microscopic surgery. Next slide, please. So this is a case example of somebody who had microsurgery. This is a DIEP flap reconstruction. You can see her before and after here. Now, one of the things I want to highlight is this is really a beautiful result, but it didn't get here in one stage. Next slide, please. So this patient actually underwent tissue expander placement at the time of her mastectomy. So that's the slide you see all the way to the left. She then underwent the free flap reconstruction using tissue from her abdomen to reconstruct both breasts. And you can see in that middle slide there's some extra skin in there. That's from that tissue from the abdomen, and that's how we watch it in the beginning to make sure that tissue is staying nice and healthy and alive. And then eventually that skin can be removed and closed up to get the beautiful result that you see at the end there. Next slide, please. Here's another example just showing a different skin pattern. This patient wanted a lift, and so it was done in a slightly different way. Next slide, please. Here she is with that skin paddle removed. Next slide, please. And then after a nipple reconstruction. I'm not going to spend a lot of time on nipple reconstruction tonight, but that's certainly something that's important to know is an option. And I thought this was a beautiful example of a very successful nipple reconstruction. Next slide, please. Those slides that I showed you before showed some really wonderful results, and a lot of that is due to the excellent technique of the surgeon who performed that case. This was done by the same surgeon, and this is a patient who had radiation. So she actually had an implant previously, so that's the photo you see on the left, and then she had some radiation, and that radiation caused that contracture of the tissue that you see there. The patient was very uncomfortable with that scar contracture. She wanted to use some of her own tissue, which allows for really letting that soften up and change the way it feels. But you can see on that photo on the right, even though this is a very good and very successful flap reconstruction, it looks quite different to the other ones. And that's just based on factors that are beyond either the patient or the surgeon's control. This was about the type of cancer she had, the care that was required for that, and the scar contracture that resulted from the radiation. Next slide, please. So at this point in time, you're probably, sorting through all these things. And if you're someone who's researching these options because it's going to be important to you or to a loved one coming up soon, you might be wondering, how do I decide between these? Which one is right for me? Next slide, please. There are a couple of major factors to consider. The first one is operative time. Breast implants are much faster. So depending on if we're doing one side or two sides, it can take us 2 to 4 hours to do those. And that's, of course, in addition to the time for the mastectomy. Tissue-based reconstruction, especially the microsurgery or free flaps that we were showing before, can take 8 to 12 or even longer, 12 hours, even longer. In terms of your hospital stay, breast implants, you're usually going home the next day or the day after. For a free flap, you're going to be in the hospital for a week, and you're going to be in an ICU for 1 or 2 days with close monitoring. For breast implants, there's no additional surgical site. You're only healing your breasts. You're not worrying about healing a big wound on your abdomen. You're not worrying about your tummy being sore after a big breast cancer surgery. For tissue-based reconstruction, you have another site that you have to heal, and that is another potential source of complications. For breast implants, you can choose to be bigger or smaller after your reconstruction. However, a major limitation of breast implants is that it's a foreign body. There's a higher risk of infection related to breast implants. There's a higher rate of failure of breast implants associated with radiation therapy. And breast implants are not a lifetime device. They will need to be switched out at some point in time. Versus your tissue-based reconstruction or your flap, that's going to grow and shrink with you. It's part of your body. It's just going to be there with you for life. And I do have to highlight here, there are lots of wonderful options we can give our patients locally. Free flap surgery is not currently available at Spectrum Health, and that's just because of some of the factors I've already mentioned here. So we have an ICU stay, a very long surgical procedure time. It's something that hopefully we'll be working towards in the future, but at this point in time, we just don't have all of the support systems in place to offer this to our patients locally. But we do have partners in Grand Rapids who offer this surgery, and I frequently refer patients to them. I'm very happy to do so if you're interested in this surgery, and they can talk to you more about whether or not you're a good candidate for that at their center. Next slide, please. There are lots of other surgical options, as I mentioned, for patients who are having breast conservation. There are options that we can do to help reshape the breast after that. There are some combination procedures where we're taking tissue and an implant. Most commonly, that's going to be the latissimus muscle, as shown here in this picture. And a lot of times that's after somebody has had radiation. And again, we're getting into some more details here, but there can be combinations. It doesn't have to be just one or the other. And as I mentioned, there are lots of revisions. We can take fat from somewhere and place it to the breast. We can do scar revisions. We can do nipple reconstruction. Next slide, please. So that's really bringing us to the end of our talk. We've gone through a lot of information today. As I always mention to my patients in clinic, oftentimes it's more than one visit to go through all of this information together.
And we do have just a couple of questions. We want to be conscious of everyone's time. This one is for Dr. Phillips, and you may have addressed this, but just so we can get this asked, can additional surgeries follow post-op reconstruction surgery of a breast implant that did not work out well? The implant size is very different in size compared to the other one that is natural and healthy.
Yes, absolutely. So revision surgeries, including implant exchange, or if you want to switch out for tissue or things like that in the future, are almost certainly always covered by insurance and can be performed as long as it's been a safe period of time since your first surgery. So we wait usually 3 to 6 months between stages. If it's radiation, we wait at least 6 months after radiation before we do any further surgery, but certainly those surgeries can be performed in the future.
Thank you. And perhaps Dr. Rapciak, you can address this question. Is there any new testing or things out there for early detection of breast cancer?
That's a great question. At this point, there are no new testings for early detection of breast cancer. Mammography is still the standard of care for breast cancer screening.
Thank you. And I should also mention too that we do have a high-risk cancer program at Lakeland, which offers some different options in terms of genetics testing and services for those that are high risk. So that's a great option as well. All right, well, those were the only 2 questions that we had today. So thank you both for your time, and thank you for everyone for joining us.
Thanks, everyone.
Thank you.